Good afternoon. The title of my topics, the effects of different additional therapies in cerebral palsy. My name is Márk Pulay, and I'm graduated in the András Pető Faculty as a conductor many years ago. And my vision is that Pető method contributes a better quality of life of patients with cerebral palsy. And my mission is to find and implement new cutting-edge technologies and additional therapies which fit the holistic approach of the Pető method. I set up three specific goals: systematic review and a meta-analysis, a pilot study, and based off the experience of this pilot study, a pre-study protocol. So let's start with the first project, the effects of additional whole body vibration in patients with cerebral palsy. But what is cerebral palsy? Cerebral palsy is caused by mostly perinatal noxa and characterized by abnormal tone, posture, and movement, such as hemiplegia or tetraparesis. We used to say that patients with cerebral palsy require lifelong therapy, and one of such a physiotherapy or conductive education, and we are looking for always some additional therapies, treatments which can be used. And one of these promising treatments is the whole body vibration. As you can see on this figure, the vibration platform can be used in different postures. And our aim is to evaluate the effects of this additional therapy on musculoskeletal system in patients with cerebral palsy. So the P is already described. I is a conventional therapy plus whole body vibration. C is those who get only conventional therapy. And the primary outcome is effects on musculoskeletal system, which can be, of course, divided in different kind of secondary outcomes. I conducted a systematic search in the most frequent databases, and you can also see my search key. And finally, I get 34 eligible abstracts. Before I start to show you my plots and my results, just some of the results because of the big number of outcomes, you have to understand the heterogeneity of the CP population. Actually, the gross motor function classification is the kind of gold standard to classify the CP patients. And as you can see, there is 5 levels. The first one is the most independent children, and the 5th level is the less independence. And based on this classification, there is a measurement system which also widely used and contain 5 different domains, and these 5 different domains can be also used separately. And it's very important that the scale is from 0 to 100, and the higher number corresponding for the better function. So it's very important because you can see that I could include 4 studies in the D domain, which is the standing domain of the GMFM. And we do a subgroup visualization. And the 2 study at the top involved patients with cerebral palsy who has higher pro-value. It means they have better function at the start of the therapy. And the other 2 studies involved patients who has very low motor abilities. Just to guess, so the first 2 is around 70% if it's the 100 scale, and the other 2 is starting from 20, 30. You can see also that there is one study which is really far from the others. The reason behind is that those patients has higher function than the others, and in that case we see that the patients who starting with a higher pro-value, they can develop quicker or better than those who have lower pro-values. This is the same situation in the other domain, which is the walking, running, and jumping, the gait parameters with the same scale. We can see here, such in the previous one, just talk about the statistics a little bit. So we see that there are tendency for changing, but it's not significant in this case. But we can say that this amount of changing it's make clinically importance of this additional therapy. So it's an additional therapy. So this is why we are not really expected very huge changes. The other outcome, which is a walking parameter, walking speed, here we can see more promising results in statistic, but the heterogeneity is also high, not as high as the previous domains. And we can understand, and it's important, that walking speed can also it's contained the step lengths. So if the step lengths of the patients are better or higher, it's of course increased the walking speed as well. So these two outcomes are walking together. So the summary, the strengths of this meta-analysis that we include only RCTs. We find few new results regarding to the previous meta-analysis. Of course, we have many limitations, such as different baseline values or the age differences, and the different outcomes and measurement techniques was also, it's make challenging us. The implication for practice, because of the promising effects, we can say that this additional therapy should be considered for inclusion in conventional rehabilitation programs. But of course, there are implications for further research, such as more RCTs with long-term follow-up. As a conclusion, we can say that there is a clear tendency to have beneficial effects of this additional therapy, but increasing the number of the RCTs can lead more statistically significant results. The second project, which is a pilot study, this is another additional therapy called pulsed electromagnetic field therapy. We had an opportunity to submit this study. This therapy has also convincing experience in disorders with abnormal muscle tone, such as SMS or Duchenne muscular dystrophy. But however, there is no evidence of this therapeutic approach in CP population. So this is why we start with a pilot or technical pilot study. Our aim is to assess the beneficial effects of this additional therapy on symptoms associated with CP. This was a single-centered pilot, which was managed in the Pető Faculty Elementary School. We involved patients with cerebral palsy aged between 8 and 12. Conventional therapy was conductive education in that case, plus this additional therapy. C is conductive education, plus the placebo or sham device. And the primary outcome was the overall stability, and we have some secondary outcome as well. We set up inclusion and exclusion criteria. Exclusion criteria such as patient with epilepsy or shunt. Here you can see the design, and I also attached a picture about the device, which is a pillow, and it can placed on the lap of the participants while sitting. And in the case of placebo group, the device was turned off because normally it has no, even if it's turned on, it has no voice or noise, so it cannot be captured. You can also see the intensity of the therapy. And finally, we include 12 participants in this pilot study. It was randomly divided to two groups, and we involved now, for the beginning, 3 different kind of measurement devices. One of them is a hand grip strength device. We didn't find any changing in both groups. There was some noticeable changing in choice reaction time of the intervention group. And in the stabilometry, in that case, that we find also some good tendencies in balance. So the strengths of this pilot study, this is the first RCT with this patient population. Number of the participants, of course, is one of the limitation. So this is the overview and of my aims. And between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. And thank you for your attention.
I would like to ask about the clinical trial that you saw actually some improvement, but this was a 4-week period. I would like to ask, do you plan to extend this interventional period, and what could be an ideal length for this to have even more better results?
We planned because we don't see any or very high changing. So there are 2 ways. One of them is that we make the intervention time longer, and/or we will change the dose or the frequency and the intensity of the device. So maybe we will do both, but with the dose we have to be very careful. Based on the literature review, there was some studies. They used this device around 12 weeks.
The question is also about the follow-up time, but regarding to the meta-analysis. You mentioned that more RCT is needed with long follow-up time. And I wonder what was the follow-up time in the included RCTs in the meta-analysis, and was it enough in your opinion?
Thank you for your question. I cannot say the exact period, but there was some study who make follow-up, but not very long time follow-up. So about like the maximum was 8 weeks or something to see the washout period. But yeah, it's needed to have more studies because most of them just do the baseline measurement and then a measurement immediately after the end of the treatment.
What do you think? What can be the reasons behind the situation that you haven't got any significant results?
Yes, thank you for the question. One of the reasons, there can be many reasons, of course. The number of the participants can be one of the reasons. Another reason, the time of the intervention. The third one is the dose, so the intensity and the frequency of the intervention. It can be also because of the measurement device are not capable, or we have to use other measurement devices. So there are several reasons, and we have to consider all of these reasons before we publish the pre-study protocol.
So about the second topic, you mentioned that there were 12 patients. Did you have the opportunity to match the base characteristics of the patients between the control group and the baseline from where they started?
Yes, of course, it was important. We tried to make the samples or the patients as heterogeneous as possible, but there was of course the randomization in who will go into the control group or who will be a part of the intervention group. Actually, we tried, but of course we have a limitation because there are many exclusion criteria, and of course, we have patients in the Pető Institute, but not as much that we can really easily make the samples very heterogeneous.